if you show evidence of vasculation, you know that follicle is mature. Generally, by the time the follicle is 18 millimeter and above, you should be having vascularization at least around 75% of the periphery of the circumference of the follicle to say, yes, this follicle is mature. Now, the endometrium is also monitored during treatment. What do we look at from the endometrium? The thickness, the morphology, and when you do Doppler studies of the endometrium, you find the subendometrial blood circulation, the resistance index, and the pulsatile index, and then the peak systolic volume around the subendometrial area. We give you idea whether that endometrium is receptive or not. We're going to take all this one by one now. Now, this is a 3D scan for follicular monitoring. Now, what you do here, what you are seeing here is a plane. Sorry, just a minute. What you are seeing here is a plane, a cross section of the ovary. So you can count, there are 4 here, but there are some that are not in this plane that you're not seeing. So this is one of the drawbacks of using a 2D scan to do follicular monitoring. But if it is 3D, we'll get to see that very soon. Now, this is a 3D follicular monitoring. What 3D does is that it will color all the follicles that are present and measure them. And then it gives you the average diameter of the follicle. Now, we've observed, I try to do a comparison between what we measure when we use 2D and what we measure when we use 3D ultrasound. We found out that the 2D measurement that we do, usually you take the widest diameter. I take about three dimensions and find the average. It usually overestimates what the true diameter is. But when you do a 3D, and it gives you this type of reconstruction, all these are follicles that have been taken different, the system, the ultrasound automatically takes different diameter and gives you the average. And studies have shown that when you use 3D to measure your follicle, and you have follicular measurement of about 14 millimeter and above. Follicles on 3D measurement that are 14 millimeters, about 60% of them contain matured oocyte. So it is something worth having. Particularly those of us who are involved in IVF really needs to strive to get your 3D machine and see the beauty of it. It does not miss out anyone. Particularly, it will also help you. You can use 3D to do your intrafollicular count. It gives you accurate number. Now, this is exactly what I was talking about. The perifollicular blood flow. In matured follicle, matured follicles, you see this perifollicular blood flow occupying about 75% of the circumference of the follicle. Now, ultrasound, particularly using Doppler, we also help you in a patient you are stimulating for time intercourse, know when to advise coital exposure to help you to detect ovulation. Once there is ovulation, the follicle is luteinized. And part of the process of luteinization is neovascularization. Vessels are formed and there's increased blood flow. If you do a scan and a Doppler study, you see what looks like a ring of fire. This is the corpus luteum, as different from the follicle. You see a ring of fire. And if you look closely, the follicle that was hypoechoic in the central hypoechoic becomes web-like after ovulation. So you see things like cobweb here. It tells you that corpus luteum has formed. Now, if you have facility for Doppler, you can put Doppler on it, and then you see this ring of fire. At this point, you can confirm that yes, whatever treatment you gave to the patient, either to induce ovulation, this is particularly useful for those people you induce ovulation and advise time intercourse. Now let's move on. Now, endometrial assessment. What do we assess in the endometrium? Just for receptivity, you want to know if the endometrium will allow implantation. And there are three things that we traditionally look at: the endometrial thickness, the volume of the endometrium, and the morphology. Now, studies have shown that yes, we do say the endometrium, the aim is to get an endometrium that is 7.5 millimeters thick. But IVF practitioners will tell you that they have achieved pregnancy, even with endometrium that is 6 millimeters, and even less than 6 millimeters. Such pregnancies, though, may have some challenges like early pregnancy loss. But all the same, pregnancy was achieved, even with the endometrial thickness that is less than 7.5 millimeters. Yes, they talked about the morphology, the trilaminar appearance. That once you have trilaminar appearance, yes, the endometrium is quite receptive. But every IVF practitioner knows that even with beautiful trilaminar endometrium, pregnancy still fails. Yes, we know it is not the endometrium alone that determines the outcome, but with good, when you transfer good embryo and the patient continues to have failure, you have transferred good 2-3 times, then that is repeated implantation failure, and most of the time the problem is in endometrium. So you have to study that endometrium further. Now, using a Doppler to assess the endometrial perfusion has been shown by studies that that is the only one that can predict, or put it in a different way, is the only one yet that can predict successful outcome. The thickness, the volume, the morphology, and the subendometrial perfusion. These are some people have considered and scored them, what they call endometrial scoring. But even that scoring system has not been found very useful. So subendometrial perfusion appears to be the only one that has predictive relevance. Now, if you look at this table, the resistance index for those people who have successful pregnancy, the resistive index is lower than those who didn't get pregnant. Now, the peak systolic volume. See, these are all indices that assesses the blood flow to the uterus and therefore to the endometrium. Now, this one, yes, of what value is it? At the time of embryo transfer, you can do this, get these values, and document them. It will help you in the counseling of the patient, particularly if you have very poor values, where you know how to counsel the patient without raising too much hope and then without causing too much despair. Now, at embryo transfer, not until recently, embryo transfer has been the clinical touch method. The clinical touch method is using landmark. And when you introduce the wireless catheter into the uterus, you allow 3 markings to be outside the cervix. At that point, you can now inject the embryo that is contained in the catheter. However, that does not take into consideration that some people have very long cervix. And then some people cervix is short, as if you are doing it without ultrasound. So you may find either you are depositing the embryo close to the internal os, which will predispose to placenta previa. Or if the cervix is short and you use this clinical method, you may just be dropping the embryo too close to the fundus, and that may predispose to ectopic pregnancy. You wonder why the baby you put inside the uterus is going to implant in the fallopian tube. But it does happen when you deposit the embryo too close to the fundus. The best point to deposit the embryo is between 2/3, between the lower 2/3 and the upper 1/3 of the uterus at this point here. And you can only accurately determine this when you use ultrasound guided embryo transfer. This has so much work has been done to prove that it is superior than the clinical method. Even several systemic review, meta-analysis, the recent one was published in 2008. They all show that using ultrasound guided embryo transfer, pregnancy rate is better, complication rates are less. When I say complication, I mean placenta previa, ectopic pregnancy occurrences. Those ones are less if you do trans-abdominal ultrasound guided embryo transfer. There's a special catheter that allows you to even do trans-vaginal ultrasound guided embryo transfer. But most people do trans-abdominal ultrasound guided embryo transfer. That's what most people do. I'm also aware that in many IVF centers, they still use the clinical touch method, which is inferior to ultrasound guided embryo transfer. I think everybody should try and embrace this method of embryo transfer for better outcome. Of course, you need the ultrasound to confirm your pregnancy. Any ultrasound should be done. Transvaginal ultrasound to confirm pregnancy when you are dealing with infertility patients. The ectopic pregnancy is quite common among them. So ultrasound is it's an invaluable tool in management of infertility. Now, one of the things that has bothered IVF practitioners or people involved in fertility management is how to manage multiple pregnancies. We all know in developed countries where the healthcare financing is not directly on the patient, they have policy, single embryo transfer policy. So that policy has been embraced in England, in Denmark, in Sweden, so many of these developed countries where the patient does not directly pay. They pay from the commonwealth of the people, form of their health insurance scheme. And then they have very good freezing program. So you can come, they are more interested in cumulative pregnancy rate there than what we do here in developing countries. Yeah, developing countries, everybody wants success. The patient is paying out of pocket, and so you want the patient to get pregnant as soon as possible. Now, what do? You find people transferring 2, 3, 4, and in some cases, I'm told they transfer up to 5 or 6 embryos just to make sure that the patient gets pregnant. Now, after pregnancy, what next? A woman has 4 embryos, 4 babies, fetus developing at the same time in the uterus. And most IVF patients, they are not that young. So you are worried, how is this baby going to come out? Now, multi-fetal pregnancy reduction is one approach. You reduce the number of babies to 1 or 2 to make the antenatal period less turbulent, improve outcome, and reduce costs caring for that pregnancy. Now, what do you do with the ultrasound? You do a vaginal scan, just like you do when you are doing your egg retrieval. You use your egg retrieval needle, locate the heart of the baby, of the fetus, puncture it 2, 3, or 4 times until it stops activity. But you must be very careful when you are doing that. First of all, you must ensure that you are going to leave the best fetus behind, and then that your procedure, the procedure you are doing, will not cause miscarriage, which is a very possible complication. In trying to reduce the embryos, the fetuses to the one that you can manage, you may actually end up losing all. But if you take some precaution, like one, how do you leave the best? You take the crown rump length and measure the crown rump length. The one with the lowest crown rump length for that gestation is the one that you should take out. And you avoid anyone close to the cervix. Avoid anyone close to the cervix. And when is this procedure done? Between the 7th and the 9th week. Some persons will inject potassium chloride into the heart of the baby, but just repeated puncture is enough to stop activity. Now, you do it between 7 and 9 weeks. That is the time when the liquor volume is not so much. If you leave it beyond that point, the fetus will just be floating inside. Now, we try to look at how well our people will accept this type of treatment, trying to improve their outcome. The acceptance value the acceptance level is less than 30% in a study that we published recently. We've done quite a few using ultrasound guided approach. So, ladies and gentlemen, we, over the past 40 minutes or so, we looked at ultrasound in infertility management. We recall use of ultrasound to make diagnosis, tubal patency test, use of ultrasound to assess the endometrial lining, set the endometrial cavity, detect things like polyp, even Asherman syndrome. The Asherman syndrome, the way it appears in ultrasound is that endometrial plate is so continuous. It just, you see this continuous endometrial plate. Tells you that patient has Asherman syndrome. But when you do solo hysterography, it gives you a better picture and even detect stuff like polyp, endometrial polyp, and what have you. Now, in ovarian assessment, you use your scan, determine the ovarian reserve. The best approach, the best technique is to, not the volume, yes, the volume, ovarian volume is okay, but the best measurement is the intrafollicular count. That gives you best, and it gives you an idea that can correlate with what you get from anti-malarial hormone assessment. And then they use your ultrasound to monitor follicular development. So you can see that at the end of the day, if you look at infertility management, from start to finish, you need a scan. You need to do scan. Either you are monitoring your treatment, or you are selecting patients, or you are trying to prepare the patient for better outcome, you need scan. So all gynecologists need this, every gynecologist needs this basic skill. We don't expect you to have to go and do level 3. No, just basic scan. And then it makes your job better. It makes it life easy for you. So what is left for me to do now is to thank all the people that made this possible, Dr. Nakudoso, and thank all the people who managed to attend this section. Jerry Wifo is there. I can see he's writing a few things. Udugun, you're welcome. That is it. Thank you so very much. While we are waiting.
I want to say a big thank you to you, Professor Aziken, for this very wonderful rendition today. Virtually different parts of the world are represented here, and I have seen a few of them, and I've asked them to quickly say a word of thanks to you.